Hi friends. The beauty of rhinoplasty is that every nose is different. It poses a unique challenge. Today we'll be talking about the congenitally flat nose, and they may make a special challenge because the skin is so less because of the congenital flatness. The nasal bones are not well developed. The nasal projection is not there. There is perinasal hollowness, and we need to improve the nose in all the directions. And at the same time, we have a severe limitation of the skin. You cannot stretch the skin beyond a limit. So here is a case with a flat nose, under projecting tip, short columella, upwardly rotated nose, and flat nasolabial angle, upturned uh, flat frontonasal angle and upturned nasolabial angle. And she is was very depressed with her nose and wanted to be look like a normal person. And here we have to plan the surgery because their choices are limited, and you need to, unless you give a good stretch to the skin, then augmentation will not be apparent. But when you use a thick curved material, there is risk of it being shown through the skin, or the skin may give away. And then when you use a cartilage graft or diast cartilage graft, it just does not give enough strength to stretch the skin. So once you open up the nose and you realize the alar cartilages are coma shaped, the middle crust of the domal area is not well developed. There is plenty of subcutaneous tissue, and they are thin and flimsy. Now we remove the subcutaneous tissues, expose the alar cartilages, and we have to increase the vertical height of the tip. That means they would require strong support, a strong build-up on which the tip projection can be sustained. And here we dissect the in between the medial crest, and we expose up to the spine. You see the spine is poorly developed, and see out the septum. The septum is there, but the caudal part is missing. There is a under projected septum, and this lake of the caudal septum, underdevelopment of the caudal septum, this is responsible for the tip, under projecting tip, flat nose, and short columella. So we have to, in order to give a three-dimensional reconstruction, first we have to increase the length of the septum. And how we do it? We do it with the help of a septal extension graft, which is buried inside the frame. Now this is, we need to have good cartilage support, and sometimes you have to harvest septum, you have to harvest rib, and at times a concha as well, and temporalis fascia also sometimes. But in this case, now one of the mistakes which I have realized, that when they see this case, the type of flat nose, straightway people jump to rib cartilage. Yes, of course, it is a key component of the reconstruction, but the caudal part of the septum is missing, but the posterior septum is well developed. So you can harvest a really good amount of septal cartilage, and which will be very useful for increasing the length of the septum, so that you are taking it out from the posterior part and increasing the length of the anterior part, then the septal extension graft. And here on the both sides of the spine, you see there is a perinasal hollowness, and unless you have to make a strong base, so that the projection which you are making, or the graft on which it is resting, this will be able to give a good projection. And here are the diast cartilage, which are from the rib cartilage, which are made and made very fine, and they are used as a fillers on both sides of the spine, and that helps in improving the dish shaped part of the face and this part of the nasal base. Now we have to make really new tip, and we have separated the alar cartilage from the vestibular skin. We have to increase the anterior posterior length, and at the same time we have to increase the lateral length. Now how we do it? The cartilage are so thin and flimsy that unless we make support from them, they will not be able to give the enough projection. The first step is to use a septal extension graft, which is from the harvested septum. This septum extension graft is fixed with the remnant of the septum, and this increases the length of the septum, and it provides a stable base for augmentation of the tip. Now we have to borrow from Peter to pay to the pan, is that we have to increase the vertical length, and when you increase the vertical length, you have to steal from the lateral crest. When you steal from the lateral crest, there is a deficiency of the cartilage, and that need to be support. So we are doing a lateral crural steal and using chips of the rib cartilage to give support, and this will be resting over the piriform aperture. And you can see that by lateral crural steal, the anterior posterior tip height is significantly increased. So this neo tip will help in the projection, and we have to suture the vestibular skin, and you can see the rib cartilage, the lateral crural extension grafts, they will be resting up to the piriform aperture. So we have a central support from the septal extension graft, the new dome from the existing tip cartilage, and lateral part which is supported by cartilage graft. Now, this is not my preferred graft for augmentation, the rib cartilage, because there is risk of curling and that wrapping, and that may look to a crooked dorsum. But we harvested the rib first and kept in saline, and remove the perichondrium, and for 1 hour we waited before we took it, and by the time it went well, and so we use that for dorsal augmentation, because unless you have a solid graft, it will not stretch the skin, and the augmentation you do will not be sustained. So in order to get a sustained thing, and we have to have a solid graft which can support the force of contraction of the skin. And we have used alar rim graft, so that the alar rims they also be supported, because this is the neck, this is a nose which looks structural strength. So we have to make the structural strength in all aspects of the nose. So we have made the tape projection, and then the alar extension, the alar rim graft, they will help to give a shape to the alar. And this is on the table, and you can see how the columella height has increased, the tip projection has increased, the alar both the nostrils, the alar rims are looking symmetrical and better defined, and there is no we have used the same skin, stretched it, we have not done any VY plasty, and because that gives a very ugly scars. Now I always say, what you do on the table, every nose looks good on the table, but the acid test is when you see the patients in the follow up. Now, this is only 4 months, but 4 months is a good time for follow up, because most of our patients travel from long distance. She's from Gujarat. She came for a follow up, and you can see there is a tremendous change in the personality of this patient. She's also kept an isotracheon, and you can see out the nose. The frontal view, you can see out there is improvement in the projection of the dorsum, the nasofrontal angle, the nasolabial angle, the alar arches, and it's completely changed her life, and she's so happy with the results. And look at in the three quarters view and see out the most difficult part is increasing the projection of the tip without causing visibility, because if you see out the invisible grafts of septal extension graft and lateral crural extension graft, they help in maintaining the tip which is staying in the position, and see out the dorsum and the nasofrontal angle, nasolabial angle, and the dish shaped the columella which was going inside and was hidden under the prominence of the lip, and you can see out that part has been projected out, because we have supported the base with the cartilage fillers, and that has changed the whole face, and you can see out really it is a three-dimensional extent of the reconstruction of the nose, and see out the increase in the vertical height of the columella, and do it without VY plasty is a task. Thank you very much. I hope you enjoyed this video.